Today we are discussing about cholera, a global health challenge. And as you all know, most of you that have always been with us, you know Dr. Paul Hart, one of our esteemed physician. So to start off, I think uh, not to take a lot of time waiting because I think I see now it's 8:05. To everyone that has managed to join as we continue the meeting, others will be joining on the way. And for your information, the webinar will be recorded. One of our moderators is Muna Mode, our program director. With me too, I'm Anthony Kimathi, the country director for the Addis Clinic. And Dr. Paul will take us through the presentation. To your information, the Addis Clinic offers telemedicine services, has a wide range of different programs, but mainly we offer telemedicine services. As some of you are joining, you heard us discuss with one of our attendees that has a problem logging in. But what we'll be doing in case you need help in creating an account, in sending cases to us, Dr. Paul is one of the physicians that attends to these cases. In case you need anything that regards to any condition management, our platform is always open for such. To our clinicians and different healthcare workers on board, continue using our platform. And for your information, the webinar today will be recorded. So anyone that will be willing to will need to reach out. Anybody that is willing to go again and listen to the webinar, I will send it to you. Any questions that you will have, we are having our the Q&A part, the question and answer part. Please input your questions as we go along with the webinar. In case you have any questions, please join and ask any questions that you think Dr. Paul might not have addressed or might have left out. Please ask in the Q&A. Even if it's something that you think that has not been explained well, please include it. And something that we need you to know is that sometimes Dr. Paul will always request for time to go back and research on the case. So in case you have asked a question or in case you need answers to the questions that have been asked, please, I request that everyone will leave me their emails. I will forward the question and answers, the presentation for today, and anything else that Dr. Paul sends to us. So for everyone in the attending participant list, I see Hussein has raised his hand before we start. Hussein, do you have anything to say? You can unmute yourself before we start. I think Hussein has managed to has put down his hand. But besides that, I just want to give Dr. Paul the room to start the webinar. Thank you, Dr. Paul. Over to you.
Thank you so much. And thank you, everybody, for attending. I know this is in your evening there, and I appreciate you taking your time. So today, our new director, Mr. Cahill, suggested that we talk about cholera because it is a significant worldwide problem, and especially in the part of the world where you folks practice. About 3 million people a year are affected, and almost 100,000 people, according to public health statistics, die because of this disease. And it's impacting, of course, countries which are not as economically stable, and it's a really major health problems. Next slide, please. So what is cholera? And I'm sure a lot of you, I'm just reviewing stuff that you know, and I'm sorry if it's uh, too repetitive. It's a bacteria, the which produces a toxin which affects us. It comes from contaminated areas, water and food, often in areas that the sanitation is not great. And the disease can progress very rapidly with major dehydration if it's not treated. And about 10% of people get into life-threatening situations. So statistically, this is a major problem that you are faced with. Next slide, please. So if you look worldwide, Africa has the highest burden. South Sudan, Angola are some of the most affected nations, but of course, Kenya and other countries definitely. Asia, there are some outbreaks for sure. Sudan has been a major hotspot, but it is in 20 countries at least around the world this current 2025 years. So it is a global problem, not just limited to one area. Next, please. So how do people get cholera? One, contaminated drinking water, which contains the bacteria. And this is probably the main source. Poor sanitation with poor sewage systems allows the bacteria to spread widely. And then food, which somebody prepares using the water which is already contaminated or from an area which is not really sanitary, can help the spread. And it does stay in seafood, shellfish, and other food from a polluted water can harbor the bacteria and then allow it to spread. Next, please. Okay, what are the risk factors? One, dense populations where you have a lot of folks living in an area that have limited resources, where you don't have access to clean water. And unfortunately, in many parts of the world, that is the case. And with poverty, where you're not able to access clean water, sanitary supplies, etc., it makes it worse. And then in situations where you've had floods, storms, it increases the risk. And finally, your access to healthcare for all conditions, but especially infectious diseases, can delay treatment and lead to fatalities, unfortunately. Next, please. So how do we recognize cholera as providers? So when you're taking your history, your patient's going to say, all of a sudden, I just started passing watery diarrhea. Some refer to it as rice water stools. A lot of folks vomit. And this comes on very quickly. If you look at the image there on your screen of an individual, dry mouth, skin change, when you go and check for skin turgor, the skin doesn't just nicely go down after you try and lift it up, but it stays there. I'm sorry about some of this from the slide where this came from, and I apologize. Once you start with your diarrhea, you rapidly lose fluid. Your eyes become sunken, you're very thirsty, your skin is wrinkled, you can get muscle cramps because you're not only passing out fluids, but electrolytes. And then you can either go into shock, organ failure, if you're not having intervention, or hopefully recovery with medical care. Next, please. So how do we diagnose? Well, one, I would imagine in most settings, is going to be a clinical assessment on the bottom. We know that cholera is present if we are practicing in an area where there's a high incidence. We'll know that patients are going to come in with this history of watery diarrhea. We know what to look for on their physical examination. They're dehydrated, they're weak, the skin turgor is diminished, their eyes are sunken. They say, hey, I'm having leg cramps. So you can make a dehydration severity scoring, and there are international scores available. You can do, you can look for electrolyte imbalance, and then you can go through other potential infections. But this is not a unique, but a very common pattern for cholera. So before you do any lab tests, before you do any other type of testing, clinically, you're going to have a high suspicion of cholera and hopefully start an intervention while you're going to do your additional testing. Now, the gold standard is to do a school culture. And that's great if you are in a facility where that is easily obtainable. But depending on your facilities, how remote you are, what facilities and what tests you can do, that may not be easily available. And that will take some time to come back. You're not going to wait for a result before you start treating. The PCR testing for the bacterial DNA, another lab way of confirming it. Dark field microscopy, again, another way. There are rapid tests that are available that can give you results in 15 or 30 minutes. I don't know, and I'm sorry, I don't know how many facilities in Kenya would have this rapid test available. If it is available, obviously you're going to want to use it. If it's not, I think your clinical assessment and judgment is the initial and the main approach. And in my opinion, we'll see in a moment, once you are concerned about cholera, you're going to start to treat while you do a testing. Next, please. Here we go. Okay, the initial treatment is rehydration. Before you do anything else, you want to start rehydrating your patient. And you're going to assess the patient whether you think they need IV fluids, or you can use an oral rehydration solution, the ORS. And that depends on your clinical assessment and how the patient is. If that patient is vomiting, we're not going to do too well with an oral solution. If that patient is, what in your judgment, not as severe and can tolerate oral fluids, you can start them off with the oral solutions and see how they're doing. And if they start to respond, you don't necessarily have to go to IV fluids. If they're not responding, they're hypotensive, their urine output is diminished, all the other signs of dehydration, then you can go to IV fluids. And also, depending on the age, don't forget when you're doing IV fluids, if you have somebody who has some cardiac issues, we have to be careful how rapidly we put the fluids in. The next step is offering antibiotics, and finally, at the same time, looking at your zinc and other electrolytes, because if you've had that, when you've had that severe diarrhea, you're losing electrolytes, and hopefully you can get a value for your electrolytes, what your potassium is, etc., so you know how much to put in to an IV if you're using IV. The oral solutions already have electrolytes in them, as you know. Next, please. Now, as you know, in Kenya and in many other countries, you are faced not with people just with one disease, but you have patients who are HIV positive and have other illnesses. And HIV already suppresses our immune function. So therefore, when somebody presents and have contracted cholera, they're in a more they're in a riskier, more severe situation than if they just had cholera and were not HIV positive. Because in those patients who have HIV and cholera, they can shed the bacteria longer, which means they can spread it to more people. They, because of the antiretroviral therapy, which could have a problem with delaying absorption of your antibiotics, you may have to extend your antibiotics besides using more aggressive replacement therapy. You've got to look at your, when you're giving your ARV medication and how you're giving it. If you're vomiting, etc., these folks may need additional nutritional support. And so what you're doing is not only treating the one cholera that your patient presented, but you're also monitoring their status with their HIV and how they're responding to a treatment that they've been on. And that makes it more difficult for the provider and not that you're not providing intensive care, but you have more conditions and more potential problems to watch out for. Next, please. Now, TB also is a major problem in your part of the world. Again, TB, as you know, weakens our respiratory system and decreases our immunity. And again, making cholera more severe. So you have to look at the fact that the medications that you're using for your TB may affect the medicines you're going to use for your cholera. You can get absorption issues. Now, I don't know how often people and where your site is, whether you have the availability of specialists who are TB and infection disease specialists who you can help treat the patient, because it's my understanding that many of the communities are more remote and patients would have to travel to get into a larger clinic or site. So therefore, the burden becomes on the local treating physician. And again, you've got to monitor the electrolytes, but also the cardiopulmonary complications that can come for the patient who has both cholera and TB as, you know, two infections at the same time. Next, please. And of course, there's malaria, another really serious problem. Just as an aside, for all the 45 plus years I practiced in the United States, I saw one new case of malaria. And I'm sure the providers I'm talking to would say, oh my gosh, we see it all the time. The challenge is you can have overlapping symptoms with malaria and cholera, severe dehydration, you've got your fever to worry about, you've got your anemia to worry about. It makes it more difficult if you've got a patient coming in with active malaria and they pick up cholera. It affects the antimalarial absorption of medicines. You have increased fluid requirements, and of course, complicating your your recovery. Again, testing is important to do as much as you can. In this case, you want to use IV medications if you've got the dual, and you're going to have to really work on monitoring them and supporting them and increasing your rehydration. And next slide, please. So before we get on to prevention, what I didn't talk about, but we could have, is your patient who's already HIV positive comes in with malaria and now cholera. So I've only talked on dual infections. I'm sure I wouldn't be surprised to hear that some of the people that I'm talking to now and your colleagues have seen people who have multiple infections, TB, cholera, and malaria, and that becomes an HIV. And that becomes a really significant problem. And here in the States, if that patient occurs, they go to specialist automatically. I don't believe that every facility in Kenya or other countries around you have that luxury. Okay, how do we prevent cholera? One, we try and improve our water supply. I don't know how feasible that is in every part of Kenya, but you can do the best you can to try and improve it. You talk about improving your sanitation, in waste management, if in your community, whatever sewage systems are, to see that they're maximized in efficiency. You promote hygiene for your patients. Make sure you're doing hand washing. Give out soap if that's something you can do. Talk to people about the general way of better improving their health. And vaccination if that's available. Again, I don't know what vaccines are available in Kenya, but that's an option if it's there. Next, please. Now, vaccines are developed, and their oral vaccines are currently, and again, this is from resources because I'm not familiar with them that much, 60 to 85% protection for 5 years. And these are the different vaccines listed. It is a problem to get the vaccines out to the people who need it. There's global shortages, there's cost barriers, and unfortunately, because of changes in the United States, not to be political, resources which were there are being greatly cut back, which is terrible. And then right now, because the vaccine has to be kept in a cold situation, they're trying to make vaccines which are more heat stable and could make it easier to distribute. Next, please. And there's new techniques. Our current methods, 24 to 48 hours, limited availability. There are some current rapid tests that we could, or people can use, which you can get an answer in 15 to 30 minutes, which would be great. And they range in sensitivity to 85 to 95%, which means, of course, that even if you clinically think your patient has cholera and you have access to one of these newer current rapid tests, if it says negative, it doesn't necessarily mean that that is the case. If it's 85% accurate, that means there are 15% of patients, significant number, who may indeed have cholera, but the test is wrong. So don't forget to go a lot by your clinical suspicion. If that patient is dehydrated, if that patient gives you the right history of their diarrhea, treat them. You're not, because the treatment with IV rehydration done properly is not going to harm the patient. It's only going to resolve and help control their dehydration. When you add medicine, as long as they're not allergic to it, you're not going to harm your patient. Also, as it says here, these can come out in the field, in other words, to small communities, but they are not 100% accurate. And there are newer generation, or what we call next generation diagnostic tools being worked on. But like anything new, that's going to take some time, no matter where you are, for that technology to be proven to be effective and then to be available not only in larger centers, but in more remote centers where often there's a greater need because you don't have all the other facilities. Next, please. And the research. And they are quite constantly looking for new ways of treating, looking at the microbiome research, genetic investigations, who are, or which of us are more susceptible to develop malaria, cholera, or other, when we're exposed, and which of us are going to get more severe symptoms. What could we do to improve our immune response? And also to look at how cholera is responding to our current treatment, because as you know, it's a common problem that the bacteria develop resistance to the agents we're using now, and we have to stay at least 1 or 2 steps ahead of the bacteria. So if there is a resistant strain of cholera, and that goes for TB and any other illness, that we're able to treat it. But this is the research that's going on, and I'm sure in the major centers in Kenya, this research is going on. Next, please. And there we are. It's an international problem. We have many agencies working on it, NGOs, government agencies, international agencies. You and your community are helping. There's the research, and we want to reach the appropriate populations. You need the clean water, sanitations, and ideally universal healthcare access. And just a note on that, in the United States, there are 30 million people who have no health care insurance or coverage. So it's not unique to just Kenya, where people don't have, good access or can afford health care. Thank you. I think that's where we are. If there are any questions, and 2 things. One, all these slides are available to you. I believe you'll be sent out a package. Also, if you have questions now, which I don't know the answer to, I will definitely research them, send it back to Anthony, and he will distribute to everybody. And if after this fact, if something occurs, please get in touch with Anthony. He'll send me the question and I will answer it. I must say, because I've done this a number of times, I've been extraordinarily impressed by the quality of the questions, by the knowledge that you folks have, and obviously the experience, because I'm talking about a condition now which I've never treated. Even though I've done all this type of medicine, I am sure everybody I'm talking to has treated cholera and knows in firsthand a lot more than I did by looking it up and putting together some slides. And thank you.
Thank you, Dr. Hart. I think, Dr. Paul, I think we have 5 questions, and as we answer these questions, please, everyone else, make sure that you ask. You can continue including the questions in the Q&A. The Q&A is open for the next 20 minutes as we answer them. So I will start with the first question, Dr. Paul. In people who handle food regularly, I think mostly that are in the hotel business, how do we make sure they don't pass it along to their customers? And I think this question was asked in case of the early stages where it has not yet been detected.
Okay, one, and thank you. Actually, I just opened up the question so I could see it. One, hand washing, sanitation in the area for food handlers. And that's something that obviously you as a provider, I don't know how much influence you have to where people are going to, purchase their food, but clearly that's something you can do. And reach out to folks. I don't know anything else you can do besides the sanitation and education.
Thank you, Dr. Paul. So the next question is, when you are talking about the treatment, you said about zinc, rehydration, and antibiotic. But there's a question on which antibiotic regimen is best for the management of cholera.
I will look that up and get to you to see if there's the latest information. I'm not sure, but you will have that answer by the end of the day.
So as somebody, and I think I'm privy to correction, as somebody that has handled cholera, most of the most basic medications that we have always used, has been CTX, SMP. That's and ciprofloxacin, and doxycycline. If I'm
Right.
not wrong, and I can be corrected, but those are the most basic medications that are cheaper to acquire and easy to get to anybody that
Right. And what I'll
is
try and look,
handling such cases.
I'm sorry, what I'll try and look and see if there's any evolving incidence of resistance uh,
Yeah.
for cholera, and if we should be considering that in modifying treatment, and what may be the indications that somebody has resistant. How could you tell if the cholera that they have is of a strain of cholera which is more resistant? Okay.
Thank you. I can see Hussein Ali has been raising his hand. Please, I think, yeah, and Abdiwali Hassan Mohammed. Please, if possible, could you include your questions in the chat, in the Q&A, so that in case you have a question, it can be answered live while everyone is listening, or I can read the question. So for every participant that is raising the hand, if possible, go to the Q&A part, question and answer part, and then include your question there, and I will read it aloud to Dr. Paul. The third question comes from Kennedy. Which minerals or electrolytes do we make sure the patient gets in the
Okay.
first hours of the
Yeah,
disease?
your potassium supplementation, because what's going to happen is when you're having really significant diarrhea, you're pouring out electrolytes. So if you can, your potassium, make sure your sodium is normal. Zinc, as was mentioned, can be added. I will get the dosages for zinc and other minerals for you, and that will be in an answer I'll get, so you know how much to give. When, how much do you add to the IV and what rate is safe?
There was another question on cardiac problems. Since potassium is part of the channel in cardiology, does lack of potassium affect? Can it cause cardiac or any heart diseases after the treatment or management of a cholera patient?
Yeah. I'm sorry, you asked me a question. I missed that. I'm sorry if I did.
Yeah, the question is on cardiac patients
Mm-hmm.
or hypertensive patients or diabetic patients that may have a comorbidity of heart disease. And as we all know, the potassium pump is one of the most common affected in dehydration. How is it affected even after treatment of such patients?
Yeah, yeah. What you have to, I mean, there you're going to have to do constant monitoring. You're going to have to look at what your initial, you're going to start off your IV, and and while you're drawing, hopefully you get your labs, your potassium, if you, and see where it's at, and add a little potassium, and then you can titrate the amount you add. You can always add more potassium to an IV bottle or an IV bag if you need to, if they're vomiting. So I think you just monitor. I think you're going to monitor what you start with for your lab results, and then titrate from there.
Thank you. I think, Dr. Paula, while you will be addressing the electrolytes, is it possible for you to include on how the filtration works and the potassium, calcium, and
Sure.
sodium exchange?
Yeah, sure. I will. Okay. So, how to supplement in somebody with cholera. Sure.
Yeah, potassium, calcium, and
Zinc.
sodium exchange.
Yes. And sodium, of course. Okay. That's easy to do. And I see the next question is about what do you do if you can't use oral rehydration solution? It's
Yeah.
IV. If the patient is vomiting, or, for one reason you can't take
What's the substitute?
IV, intravenous. If you can't get oral rehydration solutions, you use IV fluids.
And there are different IVs. There's normal saline, Ringer's lactate, dextrose. Which is the most efficient one for cholera?
I think it's Ringers, but I'll double check. Most efficient. I think you'd start off with Ringers.
Okay. So I think, Dr. Paul, in that question too, you can include on the titration and according
Right.
to body weight.
Yes. How much? Yep.
Yeah.
And also, you're going to have to body weight and your clinical assessment of how dehydrated they are. In other words, if that patient presents early on in the course, rather than if they had to travel a distance to reach you and they've been having diarrhea along the way and vomiting, and they're presenting in a much more acute situation than if they could get to you sooner.
Thank you. In the management of cholera, what's the first line management you should always start with? I think the question is, since you said antibiotic, zinc, and rehydration, in cases of first aid management, what's the first line management?
IV fluids, rehydration. That's the most important. You want to rehydrate, start your patient on rehydration, even before you would start an antibiotic. You want to get, because they're at the risk of going into shock. So you start rehydrating them. And you can start that as the patient comes in, they're clearly dehydrated, they're clearly in distress. Start your IV, draw your blood tests, do any other cultures that you think are appropriate or any other tests, but get that IV going. And then, if you're worried that that they're having heart disease, if you can do an EKG, wonderful. If you need to do, they're a diabetic, you want to see what their sugar is, great. If you're going to have to if they're hyperglycemic and you need to manage that, or hypo, depending on the situation of what they've taken or what they're taking, but start that IV. And at the same, you don't need to, you can do many things, a number of things at once with that IV going. And I don't know enough about, if you have if you draw your own bloods or have a technician there with you while you're getting the IV going, you say, I need A, B, and C testing done. And you start it together. And then as the lab starts coming back, you can say, oh, okay, this patient has, the potassium is low. Yes, I want to give more potassium. Or the sugar is, they're hyperglycemic. Yes, I'm going to treat them. All the time you're monitoring them. Once you're giving them the IV, you're checking their blood pressure. You're monitoring their urine output. This is intense monitoring.
Thank you. I think Dr. Sharlington Bovey was asking, why is it that the most of the antibiotics that are given as start doses and not as full dose regimens?
I don't know the answer, but I'll find out.
Dr. Sharlin, I think I have your contacts, and I know in the next 24 hours, Dr. Paul will be having the answer to that. So I will send it to you by tomorrow evening.
Oh, for sure. You'll have it by later today.
Thank you.
Well, actually, no. You're 8 o'clock at night. You'll have it for tomorrow.
Yeah, it's tomorrow.
I'm only 1:45 in the afternoon, so I've got tons of time.
Yeah. AO is asking, in his experience with cholera treatment, he has been giving doxycycline 200 milligrams per hour daily for 3 days. But the treatment was focused more on dehydration. Mostly the patient needs medication. We are giving, for those who don't respond to dehydration treatment and the patients that come back with symptoms with severe dehydration and hypovolemic shock. So I think A was trying to explain what they do in their setup. He's saying that in his experience, mostly 200 milligrams for daily for 3 days. but concentrating more on on uh, on uh, on dehydration to reduce to reduce chances of hypovolemic shock and severe dehydration. So I think Dr. Paul Ayo is concurring with you on what he does on the ground, making sure that they rehydrate the patient first. So I think Ayo, before I give you, I try to make sure that I can help you out on how to uh, talk because I see your hand is raised. Let me go to Konja William. How important is a diarrhea, anti-diarrhea? Yeah, this is a question that I think we should think of. How important is anti-diarrhea medications like loperamide, activated charcoal, the management of cholera?
Okay, the only way I can answer that is in my reading, that was not mentioned as part of the early treatment. So let me look it up and find out what the role is in treating malaria, cholera with an anti-diarrheal or use of, activated charcoal.
Yeah, I think, Kunja, I can try and most of the patients that you treat with anti-diarrhea medications, the biggest thing is the biggest problem with the patients that have cholera is uh, they remove everything that has been fed to them. So sometimes, as even you work with rehydration, the best thing is to make sure that the volume that they are removing, you are getting in is more than the volume that they are evacuating, because most of the patients will not be in a position to hold anything in their gut. So I think that's the most common reason why most medications are not as the first line rather than rehydration. But Dr. Paul will give an answer. Is sending questions, please. I'll make sure that you get the answers. Abdiwali as a question, as the first question, what are the main symptoms of cholera and how can they be differentiated from other, I think, diarrhea or diseases in a Somalia's context?
You know, that's an excellent question. And this is where one, your clinical experience, because cholera is not the only illness that's going to present with diarrhea, dehydration, possibly vomiting. So it's really knowing what is common in your area. For example, I mean, just very simply, it would be one of the last illnesses I would think of if a patient in the United States presented with significant diarrhea and vomiting. I don't know enough about, but I will look up because I have references to what are the other diseases in Somalia that will mimic infectious diseases that will mimic cholera, and partly is the you've got to be if the symptoms are the same, then it's your clinical judgment, and the next step would be to do what testing you could to differentiate. But any patient that comes in that is becoming dehydrated from diarrhea and or vomiting potentially, you're going to want to rehydrate them, whatever the underlying problem is. So that would be a common treatment across all the illnesses. Then the next step is, okay, do they need antibiotics? And at how critical is it that you're aware that we're dealing with cholera versus another infectious disease? And so what I'm going to have to do is find out what are the other potential infectious diseases, and how many of these or which of these are treated in a similar fashion, because some of the other diseases possibly could be also treated by the same way we're treating cholera. And then to answer the next part, how the current prevalence, I'll have to look up for Somalia, because I know that Somalia is like many other countries where there is a high incidence of these type of infectious diseases. And the barriers are obviously access to healthcare in the first place. I believe there's a shortage of healthcare providers in Somalia. I may be wrong, but I believe that's the case. So it's access, and then what facilities that these providers are practicing in. What do you have for your ability to give IV therapy, to give antibiotics, to do diagnostic testing? And these barriers would be universal for whatever illness we're talking about.
Thank you, Dr. Paul. I think for those that are asking about the diarrhea in cholera, if you wash rice, it's known as rice water diarrhea. If you wash rice, the type of water that comes out from washing rice, that's the type of diarrhea that you get from. That's the most synonymous diarrhea from cholera. So if you get a patient that is having such a diarrhea, don't even question it. Think of cholera as the first condition, because mostly the diarrhea will be white, will look white, and that's they don't even think of trying to how you will start treating them. Think of how you can start treating it as cholera as you take the other tests. Which are the best antibiotics in children and pregnant women, Dr. Paul?
I'll find out.
Thank you.
I'll find out, which are the best to use that in that population, and they'll be in the answers.
Nkonja, William, I have two answers. I have two questions that will be responded. So I have your phone number. I will send you the PDF when Dr. Paul sends it to us. I think this is Hussein from Juba Valley Development Center. I'm from an organization called JVDC, and is a local NGO working in Somalia. My question is cholera disease outbreaks caused only by poor hygiene and sanitation, or there's any other reason?
Well, hygiene, poorly prepared food, lack of sanitation. Of course, once you start getting outbreaks, it can spread from folks to folks within a family or community. And I think the cholera outbreaks are universally caused by this whole coordination of problems of one, sanitation, lack of adequate medical facilities to treat it, so and poor food, access to healthcare. So I don't think it's anything unique to Somalia. I think it's worldwide.
Thank you, Dr. Paul. The last question is coming from what specific challenges arise when treating malnourished individuals with cholera in Somalia, and how can they be addressed?
I mean, you've got to address the consequences of malnourishment. I'll look up if there's any additional therapies you should add to, besides doing your rehydration and your antibiotics, because I guess it depends, for the malnourishment, how this has affected your patient, and then how can this affect what you are doing. So I will have that as an answer.
Thank you, Dr. Paul. I think that was the last question.
Right.
So,
as I must say, I'm always extremely impressed by these questions. Again, I will have answers for everybody. And if I'm not giving enough information, or if you want, and it's really up to you, I can provide the sources of my answers. In other words, which medical journal, which article that they're taken from, if you'd like. And that's easy to do. The only question is, by giving that, I don't know how easily accessible. Some of the journals, I can just get a summary of an answer, but the whole article, you have to subscribe to that journal, which makes it more difficult to, review the entire reference.
Thank you, Dr. Paul. Before I give Eo room to ask the question verbally, I think I have another question from William. We have around 4 minutes. When do you give cholera vaccine and who qualifies to get one?
I think you give it to anybody who's at risk, and who qualifies. That I don't know how that decision is made, and I don't know whether it's based on the incidence of cholera in the community, anything about the patients, but I will get the answer, when to give it and who qualifies.
When to give it.
When to give.
There's another one. How do dams and open water sources contribute to spread of cholera?
If they have polluted water, it just spreads. And if you got a dam where you've got, polluted sewage coming into, now you've got this large area where the bacteria can just thrive. So you've got to, it depends, to get clean water, as you know, is a real problem. So it depends on how clean the water is and what is coming into it. So if you're getting, and if you have, for example, individuals who are living near that dam or the water, and they have cholera or just getting it, and they happen to be around the water and they're having their diarrhea or they're vomiting, they're just spreading that organism.
Thank you, Dr. Paul. I think Ayo, before I will leave. I'll leave this question, Dr. Paul. If you can see the last question,
I'll answer that. In other words, and I think more of that question is excellent, but it's also what are the restrictions in giving that vaccine, not only to an individual who's TB, HIV positive, but are there any other conditions where you want to be careful in giving the vaccine? And so, any other medical conditions, any medicines that a patient is on that you would, if you say, I know, for example, some of the immunizations or vaccines in the US, if they have been incubated in eggs and the patient is allergic to eggs, that becomes a contraindication. I don't know about, but I will let you know about cholera for TB, HIV, and any other conditions. What happens if a patient has had a traumatic splenectomy? Does it make a difference? There are, I think, and this is an excellent whole area that you have to know who it's safe and who there's a danger in giving any vaccine or any medicine, of course.
Yeah, and there was one, the local health authorities and humanitarian actors monitoring dam-related cholera cases, and what are the early warning systems that exist to detect cholera outbreaks linked to dam water? I think that question
that I don't know, and I'll try and find out. I don't know enough about what monitoring, even here, if you'd ask me what monitoring they do in the United States, what do they monitor for? And I'll try and find out what you monitor for in Kenya and Somalia.
Thank you. Ayo, you're free to talk.
Okay, thank you very much, Dr. Paul and Anthony. And this is to share my experience regarding the cholera. I was a focal person in 2022 and 23 during outbreak in Ethiopia, and part of the community where I'm working as a primary health care person is most commonly affected, and everywhere the outbreak is there with cholera. So in our experience, isolation was very important by the time when we found somebody with clinical sign and symptom of cholera. We isolate him and we go for his family or her family, and we'll look any person there which is the same affected with the patient, and we isolate them. And also we were putting different treatment center in the community, and if there is any sign and symptom for a person, to limit the transmission, we were isolating and treating the patient. That was very important one, and giving also education for the community, and giving a sanitary, like giving soap and clean water by the time when outbreak is is very important. And one thing very different was in by the time in Ethiopia was even the vegetables were vegetables like tomato, potato were those were very near to the soil, also infected, and there were those were also the source of the cholera. And the other is lake. And we take sample from lake and we send for the regional. All the lakes were infected, and that was my experience during treatment with cholera. And I think uh, every time, even in most of the Eastern East African country, the outbreak will be uh, always present yearly following the rainy season. So this is to give my experience, and it's very important isolation and also giving education for the pupil. Thank you.
Well, thank you. Just as an aside, I had about 4 or 5 medical missions to Gondar in your country.
Okay, thank you.
Yes. And had the pleasure of going to Lalibela. Amazing.
Okay, the southern part of Ethiopia, Lalibela, yeah.
Yeah.
Thank you for giving that update. I think we had also forgotten on the isolation part because of the transmission. I think that's very relevant, and finding other sources to reduce the transmission. We have talked about management more and forgotten about reducing the transmission, because the probability of transmission is high as you continue treating the other patients. Yeah.
Right.
Yeah. The other is, and also I want to make the part of the community where I'm working to this telemedicine platform, and please, Anthony, uh, 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 contact me, and let's make it possible for this community, this amazing platform.
I will, because I think I have you on LinkedIn. I will reach out to you, and we'll ask we'll continue with the asking, getting your phone number so that I can follow up.
Thank you very much, Anthony. I will text you there also.
Thank you so much. I think for the other question that has come along, Dr. Paul will answer it in the PowerPoint that in the presentation that we'll be creating, and I will forward to you all. Thank you, everyone. I think we are 2 minutes past the time, and I don't want to keep everyone here. Thank you for everyone that has contributed. Thank you for everyone that has managed to join today. We really appreciate the time that you have taken. Go spread the word in your communities. For our telemedicine services, they are still open, and anyone that is willing to send cases through our platform, our consults, people like Dr. Paul are always ready to respond to such cases. And in case you need more help, the Addis Clinic is always ready to help. Reach out to me. For anyone in Kenya, Somalia, Ethiopia, our code is +254, and then my phone number is 0712-559-438. And you can reach out to me through the Addis Clinic email, Anthony, ANTONY, @addisclinic.org. So in case you need any help, in case you have any questions, please reach out to me. Thank you, everyone. Thank you.
Thank you so much, everybody.
We will let you know. Dr. Paul, bye-bye.
Bye-bye. It's a pleasure again. See you soon.
Bye-bye, everyone.